Good evening, everyone. Welcome to the webinar on Lymphoma India Forum of Experts. It gives me great pleasure to invite our first speaker, Dr. Jeyhan Dhabhar, consultant medical oncologist and hemato-oncologist, Wockhardt Hospital, Mumbai. Over to you, sir.
Hi, good evening. Thank you for the kind introduction. I would request you to please share my slide deck.
Sir, is
So
it
today,
visible?
no, not yet. It's my display slide only. So I think I have to change the PPT to my PPT. Yeah, excellent. So today I'll be talking about the abstract that was presented in ICML, which is brentuximab with AVD in previously untreated patients with advanced classical Hodgkins lymphoma. So this was an Italian real-life multicentric study, and which was first published in June 2025. Next slide. Next also. So this is just the snapshot of the entire abstract. Next slide. So how was this study conducted? So it was a retrospective, multi-center real-world study, and it was primarily based in Italy. So around 137 patients who were randomized to the BV-AVD arm versus 92 who were in the treated with ABVD, and all of these patients were stage 4 classical Hodgkin's lymphoma. So the objective of this study was to evaluate the efficacy as well as the toxicity of brentuximab AVD with our old friend ABVD. The response assessment was done with a PET CT. There was an interim PET CT as we normally do it, and an end of treatment PET scan. The other assessment factors was peripheral neuropathy and the hematological toxicities. One of the primary endpoints was peripheral neuropathy. The secondary endpoints was PFS, the CR rates, what was the need of dose modifications, infections, and all of this. Next slide. So when you look at the real world outcomes, the CR rates, the complete remission rates were somewhat similar with BV-AVD versus ABVD. At the final end of treatment, PET scan was 90% with the BV-AVD versus 87%. The survival events were slightly fewer, plus 13% versus ABV in the BV-AVD versus 26% in the ABVD arm. The 1 year PFS benefit was also significantly better for BV-AVD. So the 1 year PFS was 91% versus 80% for ABVD. The interim PET showed a significant difference in survival by the dual score. So patients who had a good response on the interim PET are the ones who ended up having better overall outcomes. And this is something that we already know of. Coming to the main factor is peripheral neuropathy. So this is also one of my worrisome side effect whenever I've used brentuximab so far. So in most of the patients that I have given BV, 60 to 70% patients have developed peripheral neuropathy. So even in this real world study, the peripheral neuropathy was of course higher for the BV-AVD arm versus the ABVD arm. Neutropenia and infections were similar in both arms. And those adjustments were more commonly seen in the BV-AVD. So to conclude, BV-AVD showed a high efficacy in stage 4 classical Hodgkin lymphoma. The peripheral neuropathy rates were slightly lower than what we saw in the primary Echelon-1 trial. And the interim PET, as we know, predicts the overall outcomes. I would like to say that, the neutropenia infection parts were in this study, they've said it is comparable. But what I have seen in my clinical practice and in all the patients that I've given brentuximab so far, I have about 10, 15 patients so far that I've used brentuximab. And I've seen much lesser incidence of neutropenia and lesser incidence of infections because of the liberal use of growth factors. And my use of GCSF is very limited when I'm using ABVD. I'm very concerned about the lung toxicity. That's why I absolutely avoid GCSF when I'm using ABVD. But with BVAVD, in fact, it's mandatory to use GCSF, which makes a huge difference. And I think the neutropenia and infection is very much controllable. Next slide. So you can see the 1 year PFS rates was 91% for BVAVD versus 80% for ABVD. So a significant PFS benefit that we saw with the BVAVD arm. Next slide. So this is what summarizes this abstract. It's short and sweet. So now I'll be talking about this very interesting case I feel that I had recently. So it was a transformed lymphoma, a CLL, which is transformed to, a Hodgkins lymphoma. Next slide. So I had a relatively young patient. So he was 50 when he was diagnosed. He was initially treated in a outside hospital before coming to me. So he was diagnosed in a routine health checkup. He just had some borderline fatigue, some weakness, for which he got a health checkup done, in which his WBC counts were raised. He had a classical CLL peripheral picture. A flow cytometry was done, which confirmed the diagnosis of CLL, a peripheral blood flow cytometry. A FISH test was done, which was 13q34 deletion and heterozygous ATM. So all suggestive of intermediate risk CLL. Initially, he was more or less asymptomatic and he was kept only under observation for a year. Next slide. In December 21, he had significant weight loss, significant fatigue, which was hampering his day-to-day activities. So something like, they was developing B symptoms and the oncologist outside decided to start him on venetoclax and venetoclax was started. He had a good improvement in venetoclax, but he was not compliant. He was staying, for a few months in Mumbai, a few months out of the country. So he was not compliant for follow-up, not compliant on taking venetoclax. So he possibly discontinued to lost to follow-up. We don't know. Next slide. So for around a good, December 21 to 23, he was, not really compliant, but when he came back, he had got a PET CT done, which showed a reduction in the nodal burdens, reduction in the marrow lesions, but still some, I think there's one slide you just skipped in between. So you can go up. Yes. So this is what we had. July 23. So from December to July 23, he came with pedal edema. So from December 21 to July 23, he was on venetoclax on and off. In 23 July, he had some symptoms for which he came. He had balanitis. He had some pedal edema. He had lymph node enlargement. A PET scan was done that time, which showed progression of disease as expected because he was not compliant with venetoclax. There were multiple supra-infradiaphragmatic lymph nodes with some new bony lesions also. So he was then started on acalabrutinib. Next slide. So around 3 to 4 months on acalabrutinib, he had a good response. A PET showed a good response. Acalabrutinib was continued. Next slide. So somewhere in April 24, so from July 23, he was started on acala to April 24, he again developed fever, cough, significant weight loss, quite frail. His PET-CT had shown progression in the lymph nodes all over. And he was then started on Veneto with Acala. So he was already on acalabrutinib and venetoclax was added. Despite that, he had persistent high-grade fever and persistent weight loss. So this is when he came to me after all of this being done on Veneto and acalabrutinib without any clinical improvement. Next slide. So the first thing when he came to me is I got a fresh PET scan done, and of course it had shown a gross, progression disease all over, progressive disease. His lymph nodes had increased significantly. And this time it was not looking like one of those CLL PET scans that we see, the CL, SLL picture with a low grade activity. They were angry, high uptake lymph nodes that we saw throughout the PET scan. So the first thing I did is I got a fresh biopsy done. And to my surprise, it was a classical Hodgkin lymphoma. I got the blocks reviewed also, and at 2 places it was confirmed to be a Hodgkin's lymphoma only. Next slide. So, the literature that we have transformed from a CLL or an SLL going into a Hodgkin's lymphoma is quite rare. There are no standard guidelines that we have for treating these patients. We always knew that this kind of a Richard's transformation carry a poor prognosis. So we had to put our best foot in front, and I started the patient on brentuximab with AVD. His interim PET showed a significant improvement, and I continued brentuximab AVD. Next slide. After the fifth cycle, just prior to the sixth cycle, he had some PCP pneumonia, which was very much manageable. It was a mild infection. He was hospitalized for a few days, managed very well on Septran. We managed to complete his 6 cycles of BV AVD, and we got a end of treatment PET scan, which was showing a complete metabolic response. So this was in 26th August 24. Again in December or Jan, I got another PET done, which again showed a disease-free status. So he's still in follow-up with me and in complete remission. Next slide. So this is pretty rare to see. So 0.5% of CLL patients can transform to Hodgkin's. So most of the Richards transformation that we see are an NHL to DLBCL. So there are two types of the two patterns that we see of this transformation. One is a type 1 pattern where we have the Hodgkin's-Steinberg cells within the CLL clone, which then starts replicating. And second is a de novo classical Hodgkin's from an inflammatory background. So the clonality that we see is 40% of them are related to CLL, while 60% are independent. And previous slide, please, again. Yeah, so there's a strong EBV association that we see. So basically, the pathogenesis is immune dysfunction, EBV, and plus the prior therapy which the patient has received. Next slide. So usually these patients present with the classical pre-symptoms, how any other Hodgkin's would present to us. And usually it is around 4 to 5 years post the diagnosis of CLL, but can be anywhere from 0 to 15 years. A biopsy is mandatory to confirm a transformation, and they're treated similar to how we treat Hodgkin's patients as of now. The interesting fact is that these patients, the ones who transform to a Hodgkin's, tend to do better than the ones who have a NHL transformation. And of course, brentuximab and the newer immunotherapy options are also, they play a very important role in managing these patients. So if Advani sir or anybody has any experience with a CLL or SLL transforming to Hodgkin's, I would be glad to hear from them also. Next slide. Thank you. Thank you for patient listening.
Thank you, sir. I would like to welcome our next speaker, Dr. Suraj Chiraniya, Senior Consultant, Hemato-oncologist and BMT Physician, MOC, Thane, Mumbai. Over to you, sir. Dr. Suraj will log in sometime. So we'll go with the next speaker talk. Dr. Ankit Raiyani, hematologist and BMT physician, Cure Hematology Clinic, Ahmedabad. Over to you, sir.
Yeah, thank you so much. Let me just share my slides. So I hope the slide deck is visible.
Yes, sir.
Yes, sir.
Yeah, so I'll go ahead. So my job today is to discuss about Hodgkin lymphoma, whether we can complete a treatment in a shorter span compared to standard 6 month therapy. Uh, I'm really grateful for the organizing committee to invite me for this talk. So we all have this question in mind whenever we see a patient, uh, newly diagnosed patient with Hodgkin lymphoma. What will happen after 6 months, within 6 months, and after completion of therapy, after a few years or few decades down the line? What will be the long-term complications? And similar concerns are also shared by the patient and the relatives. So this is a crucial question. Can we decrease the treatment burden on Hodgkin lymphoma patient? So fortunately, we have some means by which we can decrease the duration of treatment and allow the patient to uh, join the community and contribute to the community in a shorter span. So obviously, there are certain advantages of shorter treatment. It will decrease the burden of treatment. Patient will have theoretically less immediate adverse effects. There are less chances of opportunistic infection as the immune installation will start once the therapy is finished, and the patient will have early rehabilitation back to their routine. And ultimately, uh, often ignored side effect, long-term sequelae and adverse effect, the chances will be less when the patient will receive less treatment or shorter treatment with adequate efficacy. So let me just start with a case. Uh, IPS 1 risk assessment, uh, Ann Arbor stage 2A. So basically a favorable risk, limited stage disease. Uh, Usually we start with ABVD in these patients. Uh, Let us see what NCCN guideline, the recent edition recommends for these patients. So either we can go ahead with ABVD 2 cycles followed by a PET CT scan. And if the PET CT scan is showing a Dewey score of 1 or 2, is CMR. In that case, we can either combine with radiation therapy, called site radiation therapy, and call the treatment as completed. This will give the treatment duration of roughly 3 months. So this fulfills the criteria of 3 months. And if you go ahead with chemotherapy only, then we need the patient to undergo 2 more cycles of ABVD. In that case, the treatment duration will be 4 months, still manageable and agreeable with the patient. And if the patient has unfavorable criteria as defined by GSHG, their ESR is high, external lesions are there on the 2 nodal sites, then patient will receive 1 more cycle of ABVD followed by 30 gray of ISRT, and this duration would be in 4 months. As compared to that, when the patient does not have CMR at the early interim PET, in that case, those patients will require either ISRT that will complete the treatment in 3 months. But these are rare patients where no unfavorable criteria is seen. Most of the time, we go ahead with chemotherapy alone, and we do 4 more cycles of ABD. So we complete total 6 cycles of ABVD or ABD, and the duration would be 6 months. Or else we can go ahead with combined modality treatment, 2 more cycles of ABVD followed by a 30 gray ISRT. Again, the treatment duration would be 5 months. So from this discussion, we can glean that those patients who have achieved CMR after IPET 2, those will have to receive less treatment and have better outcome as compared to patients who have metabolically active disease after 2 cycles of ABVD. So early CMR on iPad 2, it decreases the duration of treatment in limited stage CHL. And this has been well established, and we all have been practicing this. Similarly, in stage 1 or 2, but unfavorable CHL, either bulky disease or lymphadenopathy, etc. So in those patients, we give ABVD 2 cycles followed by restaging and at least 2 more cycles of ABVD if the DUV score is less than uh, or equal to 3. So in that case, the treatment will be completed by 2 plus 2, 4 months, and followed by radiotherapy. And other option is to give AVD 4 cycles. And another scenario is where the patient does not respond to initial therapy and the DUV score is 4 or more. In that case, we have to give at least, I would like to escalate to Bracard, but at least, if not possible, at least we have to do ABVD 2 cycles and then restage, followed by PET scan. And if the patient is in remission, we can give radiotherapy. This can be completed in 4 to 5 months. So those patients with unfavorable risk factors with a limited stage can also hope to complete that treatment in 4 to 5 months. As compared to that, in advanced stage disease, we don't have till now we don't have any regimen which is less than 6 months in duration. So this is another case where the patient has IPS score of 3 with a stage 3B disease, and patient is a young patient. So we need to be very concerned about fertility preservation. So what are the standard treatment regimen for stage 3-4 advanced stage disease? So either we go with Nivo AVD or Bracard. In this case, the treatment duration would be 6 months, or else we can go ahead with ABVD followed by restaging and 4 more cycles of ABVD. So that would be again 6 months of therapy. And other option is to escalate to Bracard if the patient does not have a CMR. In that case, the patient will receive total 6 months of therapy with Bracard regimen. So this is the standard sort of treatment proforma for patients of advanced stage disease. So there is one more addition. If we use the most effective treatment upfront, other than starting with ABVD, what if we can start with a Bracard regimen? So this is one more approved therapy, first line use of brentuximab incorporated in a Bracard regimen. So 2 cycles of Bracard followed by a PET scan. The patient is in CMR, DUV score of 3 or less, then only 2 more cycles of Bracard, and then we restage with PET CT scan and document that the PET scan is still negative, then the treatment is completed. So total 4 cycles of Bracard, and that would be around 4 months of therapy. And this is achievable even in patients suffering from advanced stage disease, stage 3-4 disease. So I think we should be able to use this therapy in selected patients, young patients, where we don't want long-term or short-term toxicity, and we don't want to compromise on the efficacy part of the treatment. So when the patient of stage 3-4 disease receives Bracard, and when iPad 2 is in complete metabolic remission, then total duration 4 months. So this is again seen in this table, where Bracard can give an option of 4-month therapy if the patient is responding well to the treatment, as seen by iPad 2. So this has been adapted from a multi-centric huge trial incorporating more than 1,500 patients called HD21 trial.
So sorry to interrupt. Sir, your voice is very low, sir. Could you please keep your
Okay.
mic?
Yeah, sure. So let us talk about HD21 trial. So it was to assess the efficacy and tolerability of PET-guided Precard regimen versus escalated BCOP in advanced stage classical Hodgkin lymphoma. It was a phase 3 open label trial, and I think total nine countries were participating. Total 233 study sites were enrolled, and total number of patients were 1,400 plus. So those patients with age between 18 to 60 years with advanced CHL without any prior treatment for Hodgkin lymphoma were included, and those patients were divided into two groups. One group received dose escalated ECOP, and equal number of patients received Precard, total 2 cycles. This was followed by an interim PET-CT scan, and patients with PET2 negative, PET2 showing CMR, either received 2 more cycles of Precard and escalated BCOP. As compared to that, those patients having PET2 positive showing disease activity received total 4 more cycles of escalated BCOR or Precard according to their group. And then the end of treatment PET scan was seen. And depending on the PET scan positivity, patient had consolidative radiotherapy if required. This was followed by a long follow-up for the patient. So this is the uh, comparison between BCOP and Brecard regimen. We can straight away see that the dose of etoposide and is low. The dose of doxorubicin cyclophosphamide is equitable, and the patient with Brecard receives brentuximab, and patients on BCOP therapy receives vincristine, procarbazine, and prednisolone. So we all know that prednisolone, vincristine causes neuropathy. Procarbazine is associated with gonadal toxicity and secondary cancers. So these toxicities can be avoided by putting the patient on Precard regimen. So let us also see the primary outcome, and that was treatment-related morbidity. It was 42% with patients undergoing taking Brecard regimen as compared to 59% on escalated BCOP regimen with a relative risk of 0.72. This is significantly lower in Brecard regimen. Next would be primary outcome. Another primary outcome was progression-free survival. So it was more or less comparable in patients receiving Brecard regimen. It was 94% at the end of 4 years. As compared to that, patients receiving BCOP, it was seen 90% at the end of 4 years with a hazard ratio of 0.66. So a small per certain improvement with a Brecard regimen. This was seen throughout the study period. Start from beginning, and it was maintained till the follow-up of 4 years. Another outcome was comparison between PET2 response and progression-free survival. So PET2 negativity, it was clearly associated with a favorable progression-free survival in both treatment groups. But the benefit of Brecard was more pronounced in PET2 negative patients. So those patients who achieve PET2 negativity, they did well on both arms, Brecard as well as BCOP. But the benefit of Brecard was more pronounced in PET2 negative patient, and those patients had a very good PFS as compared to PET positive patients. So this is a forest plot depending on the patient characteristic, disease characteristic. Left side is favoring Brecard, and the right side is favoring BCOP. So you can see, we compare this. Apart from patients between age of 50 to 60, all other parameters were showing a better outcome with Brecard as compared to escalated BCOP, whether that can be age, patient sex, IPS score, patient's disease stage, and clearly, one clear benefit was if the patient had received 4 cycles. In that case, the patient who had received 4 cycles of Brecard, they did much better as compared to patients who had received only 4 cycles of BCOP. So, conclusion could be that the patients who have received 4 cycles of Brecard were in uh, remission at interim PET and end of treatment PET. They are they would be more probable to retain their remission and have a longer progression-free survival as compared to patients who have received escalated BCO. What about the secondary outcome? So OS almost comparable. Hodgkins disease it can be easily salvaged even with primary relapse. So there was no benefit overall survival in such a short duration of time. So 4 years is too short a time to see the actual overall survival benefit between two regimens. Hopefully, we will see long-term data, and maybe it can favor one regimen over another. That would be very crucial for adapting the regimen in our patients. But overall, as of now, it is 90%, 98% versus 98% for both arms. Another is gonadal dysfunction. So female patients receiving Brecard, 95% had a gonadal function recovery at the end of 4 years. As compared to that, female patient receiving EBCOP had a 72% recovery. So significant difference in gonadal function recovery and clear-cut benefit of Brecard over BCOP. Same male patients receiving Brecard, 86% had a recovery of gonadal function as compared to only 39% receiving escalated BCOP. So BCOP, one of the reasons for avoiding BCOP even in extensive or advanced stage disease is gonadal dysfunction. ABVD, we don't see so much gonadal dysfunction as compared to BCOP. So many of us still start with ABVD, but now we have one more regimen, which is uh, which does not have that much toll on gonadal function of the patient. So uh, this is one more crucial point in favor of Brecard as compared to BCOP. So I will not go into detail of this other adverse events. So, but the only thing is that almost all of them were comparable between Brecard and EBCOP. Neuropathy was less in Brecard as compared to BCOP. Otherwise, more or less, all the toxicity profile was equal. Coming to treatment adherence and compliance. So patients were started on highest dose of treatment for both regimen, and those reductions were more frequent with escalated BCOP as compared to Brecard, mainly because of leukopenia seen with escalated BCOP, and in Brecard it was mainly because of thrombocytopenia that was seen during the treatment, and around 78% of the patients receiving Brecard were able to complete the full dose treatment, while only 59 or 60% of the patients were on full dose treatment at cycle 4 of stage. So around 40% had a dose reduction with BCOP, and only 22% had a dose reduction when receiving Brecard. So brentuximab was terminated only in 2% of Brecard patients, while vincristine was terminated early in around 18% of the patient due to neuropathy. Risk of secondary malignancy, it was almost comparable. 19 patients on Brecard as compared to 13 patients on BCOP, but the ratio was 3% versus 2%, so most comparable. So let us see the timeline or evaluation of the treatment strategy for classical Hodgkin lymphoma. It all started with ABVD. Was standard of treatment. It has been standard of treatment for a long time. still is a standard of treatment for many patients. And followed that, there came a RRHL study, which gave us option of removing or withdrawing uh, bleomycin. The interim PAD 2 was showing CMR, and it showed a PFS of 82%, even with withdrawal of bleomycin after 2 cycles. After that, we saw results of Echelon 1 trial, where brentuximab was incorporated instead of bleomycin in AVD versus ABVD standard treatment. In this, the PFS was 84% at the end of 6 years. And the recent trial published is HD21 trial, where we saw PET2 guided record versus EBCOP comparison, and fabulous PFS, 4-year PFS of 94% as compared to 91% with escalated BCOP. So with PET guided record, if the patient has PET2 negative, then we can curtail the treatment. And ultimately, the patient will receive a very lower dose of, significantly lower dose of doxorubicin, 160 milligram per meter square over the complete treatment. As compared to that, in record 6 cycles, it would be 240 milligram per meter square, but it is still lower than ABVD based regimen, where the patient will end up receiving around 300 milligram per meter square of doxorubicin over 12 doses over 6 months. So doxorubicin exposure more than 200 milligram per meter square, it is associated with a 1.5-fold increased risk of breast cancer in Hodgkin lymphoma survival. And we all know that cardiomyopathy that happens later on with anthracycline treatment, and unfortunately we have no way of avoiding it in patients who end up having it. So less anthracycline exposure is good for patients' long-term survival and well-being. So this study had a very robust design, large cohort of 1,500 patients. All the reports were reviewed centrally and validated to maintain the uniformity in the patient outcome reporting. And it was conducted in several countries at different levels of patient care. Some were reference center, some were secondary care center, so on. And it sort of reflected the real world condition where we are going to use this regimen. So with this, the study was empowered to show the clear benefit of record as compared to BCOP in clinical practice. So these are the key advantages of record: superior efficacy, 4-year PFS of 95%, even in advanced stage disease, advanced stage lymphoma, Hodgkin lymphoma disease, and it improved the tolerability of the patient because more patients were able to complete their treatment with a full dose as compared to escalated BCOP. It helped in preserving the fertility of the patient, both males and females, as compared to EBCOP. And 64% of the patient had PET2 negative, and they only had to receive treatment with the 4 cycles of therapy instead of 6 cycles, which is otherwise mandatory. So shorter treatment, better outcome, less toxicity, improved tolerability. So win-win-win situation. So that is why the NCCN guideline has incorporated Bracard as a first-line therapy in classical Hodgkin lymphoma. So this is the conclusion. Bracard is significantly better tolerated. Recovery of TRMB is around 99% or more after 12 months, and normalization of quality of life. It has improved feasibility up to 25% higher rate of full dose treatment as compared to BCOP. and 16% less dose reduction of the tubulin inhibitor. That would be MMAE with brentuximab, and in BCOP it would be vincristine. So efficacy of Recard is superior to EBCOP with unprecedented PFS of 95%, and get to with a mature follow-up of around 4 years. More than 50% of the patient only had to receive 4 cycles to achieve a PFS of 95% in advanced stage Hodgkin lymphoma disease. So this is a dream come true for patients as well as clinicians. And the cumulative dose of cytotoxic drugs were very low as compared to the other standard regimen, and that way we can avoid cardiomyopathy and secondary cancer uh, in those patients. With this, I would like to conclude. Thank you so much.
Thank you, sir. I would request Dr. Suresh H. Advani to give expert comment. Over to you, sir. Okay, I would like to invite our next speaker, Dr. Suraj Chiraniya, Senior Consultant Hemato-Oncologist and BMT Physician, MOC Thane, Mumbai. This session is supported by Takeda. Over to you, sir.
Hello, good evening, everyone. I'm Dr. Suraj Chiraniya, consultant hematologist and transplant physician for MOC Mumbai. So, thank you, Takeda, for inviting me, and Suresh Advani sir for giving me opportunity to have such an interesting session. My session will be transforming frontline treatment of Hodgkin lymphoma. So, these slides are provided by Takeda. So again, thanking for the same. So if we see the challenges in managing the stage 3 and stage 4 Hodgkin lymphoma, uh, am I clearly audible and my slides are moving? Hello, Sophia. Are my slides
Yes,
moving
sir.
and
Yes,
I'm
sir.
audible clearly? Okay,
Perfect,
sure.
sir.
So the challenges in stage 3 and stage 4 lymphoma has to be addressed, because if you see the in stage 1, stage 2 stages, the most of the patients respond very well. All the challenges of relapse and toxicity happens in stage 3 and stage 4. So sometimes the traditional chemotherapy of ABVD may not be enough in such things. So we need to address that. So there is a weapon, brentuximab, that has come into the picture. The studies are done in Nicolain 1 trial that supports this. So I will take you forward in this presentations. So if you see the incidence of the Hodgkin lymphoma is a bimodal. So if you see in 20 to 34 years, there is a peak, and then more than 75 years. And if you see the age matters most, because as the age is more than 60, the survival, the overall survival is inferior compared to the young. In less than 60, it is 90%, while it drops down to 58% in a patient's older than 60 years of age. So treatment failure always remains a risk despite high cure rates with multi-agent frontline therapy for advanced Hodgkin lymphoma. If you see, more than 80% of patients with Hodgkin lymphoma are curable, but which are in the early stages, or which are young patients like 15 to 39 year of age. So among all the patients of CHL, 5 to 10% have a primary refractory disease, and 10 to 30% will people will experience relapse after the initial response. Among patients with advanced HL treated with first-line ABVD, up to 30% of the patient will progress or die within 5 to 7 years. So there is unmet need for treatments that reduces the relapse rate in patients with advanced Hodgkin lymphoma. Uh, and most of the people are young, so the toxicities are also we need to look after. These are the short term and long term toxicity. The acute treatment related toxicities like pulmonary toxicity, like acute interstitial bronchitis, pneumonitis that can happen with bleomycin, cardiac toxicity with the anthracyclines, or radiation therapy can also increases the risk. The long term problems like fertility issues, because most of the peoples are very young people, so the fertility is always a concern with such people. Then endocrine dysfunction like hypothyroidism happens in 60% of the people. Secondary malignancy secondary to the radiation therapy, while the breast cancer is also increases with the doxorubicin. And death can result due to the acute treatment related toxicity, secondary malignancies, or interstitial diseases or disease progression. So there is always, while maintaining the cure rate, there is a dictum to prevent the short-term as well as long-term toxicity in patient treated with the multi-agent therapy. So if you see the treatment of HL is almost always provided with the curative intent. So whenever we see any Hodgkin lymphoma patient, we always tell it's a curable, and our aim is to cure rather than palliate such patients. So if you see with the frontline treatment, almost 80% of the peoples are curable. If these people relapses and if they are transplant eligible, the cure rate drops to 50% even with the transplant. Or if they are not transplant ineligible and they relapse, the survival chances are less than 50% and median OS of only less than 3 years. So if you see the cure rates in stage 3, stage 4 Hodgkin lymphoma, the treatment like ABUD like regimen is associated with event-free survival and um, freedom from survival rates of 62 to 73% over the period of 4 to 7 years. So if you see the challenges is to increase the number of patients who achieve long-term remission while reducing toxicity and the risk of long-term side effects. So our aim is to cure the patient without causing much of short and long-term toxicity. So challenges in treating younger patients is maintaining a long-term remission and potentially many years of life after Hodgkin lymphoma. It is therefore important to consider the late effects and in challenges in treating elderly patients, because 1/3 of the patients are older in Hodgkin lymphoma, and age is a very strong predictor of survival in Hodgkin lymphoma. So chemotherapy, older patients typically have less tolerance to the chemotherapy and experience the excessive toxicity. So that's why sometimes the therapy delays and dose we need to reduce so that place them in the chance of the relapse in the future. So in India, approved treatment regimen in frontline Hodgkin lymphoma, ADCETRIS means brentuximab plus AVD is a approved treatment regimen in frontline Hodgkin lymphoma. Usually, if you see the two extreme ABVD, that is mostly a daycare therapy, while BCOP might require the admissions. So the brentuximab AVD bridges the gap between the two, so that you have a long-term remission while maintaining the daycare regimen for such patients. So what defines success in Hodgkin lymphoma? The treatment goals and the survival. So cure is the ultimate goal, but sometimes overall survival reflects the long-term survival outcomes, and the brentuximab AVD aligns better with the OS-driven decision making. So if you see the what is the brentuximab? It's a innovative CD30 targeted antibody drug conjugate, because most of the Sternberg cells they express CD30 uh, in almost 100% in the Reed Sternberg cells, but sometimes in other peripheral T cell lymphoma also. So what brentuximab cause? It binds to CD30, then these CD30 cells internalize these molecules, and they what after the internalization, they traffic there is a trafficking to the lysosome, where there is a release of the cytotoxin molecule MMAE. So it leads to the microtubule disruptions, and it leads to the death by apoptosis of these Hodgkin lymphoma cells, like Reed-Sternberg cells. So the characteristic of the CD30 is also because these are not expressed in the normal cells. So that's why the toxicity is spared, so that we can tell them these are as good as a guided missiles, just targeting the enemies rather than a normal civilians. So what does Ecolian study showed? So this study compares between the brentuximab AVD versus AVD as a frontline treatment in the advanced stage 3, stage 4 lymphoma. It's a open label global randomized phase 3 trial, and it compares both the studies. So patient population previously untreated, treatment naive Hodgkin lymphoma, age more than 18 years, stage 3, 4, and ECOG performance is good 0 to 2. So these people, these around 1,334 patients were randomized 1:1 between ABVD versus the brentuximab AVD. The brentuximab dose was every 14 days, and the dose was 1.2 mg per kg. And follow up every, and then end of treatment PET scan was assessed, and then follow up every 3 months to 36 months, and then every 6 months till the study closure. So the PET scan, if at the end of 2 cycles showed any DS score of 5, means a progressive disease, then the patient was given the alternative treatment. The primary endpoint was modified progression-free survival, and key endpoints was event-driven overall survival. So if you see the disease characteristic comparable between the two arms, these the baseline patient characteristic in terms of the sex, ethnicity, then the median time since the diagnosis region, these are almost equal in both the arms, so that there are no co-founder bias. Mostly these are the treatment outcome dependent changes in this population. Similar for the baseline disease characteristic like staging, IPS scoring, ECOG performance, B symptoms, bone marrow, and extranodal involvement was, the numbers are almost same in both the arms, so that the data is related to treatment only. There are no confounding factors in the baseline characteristics. So if you see the brentuximab but AVD demonstrated a PFS benefit versus the ABVD. If you see the primary endpoint, probability of 2-year modified PFS, if you see there is hazard ratios 0.77, means 23%. There is a better PFS in brentuximab arm at the end of 2 years. Probability after 6 years PFS is 32% better. Hazard ratio was 0.68, and at the 7 years it maintained the same. So in all the initial 2, 6, and 7, the brentuximab is a early winner in all the duration. So statistically significant difference in favor of brentuximab arm compared to ABVD at the 2 years, and this maintain at the 6 and 7 years of follow-up. So if you see the secondary endpoint, overall survival benefit, also at the age of 2 years 27% benefit, at the age of 6 years 41%, and at the survival OS at the 7 years is almost 38%. So almost the survival overall survival was also maintained from 2, 6, and 7 years in the brentuximab arm. And if you see in key subgroup of patients, so in stage 4, it is almost 51% reduction of in risk of death. Age less than 40 is almost 61%, and in age less than 60, it is 51%. And if you see the subgroups like baseline extranodal sites, almost 47%, and baseline extranodal diseases more than one, it is 66%. So it brentuximab arm provides long-term assurance in survival benefits with this Echelon 1 7-year update study. So if you see, this is very interesting connect study. It is by the healthcare professionals in terms of outcome, how they place the brentuximab. So almost if you see the overall survival, 5-year EFS, potentially cure rate and PFS, and long-term toxic safety profile and great reducing the toxicity, reducing risk of relapse, almost from 75 to 91% of the healthcare professional recommends the brentuximab based upfront therapy in such advanced stage disease. Um, and this is very interesting connect studies. So the other thing, if you see the connect study, the brentuximab plus AVD is the first choice in first line for various high risk stage 3, stage 4 profiles. If you see the healthcare professional who prefers this are in case of bulky mediastinal disease, almost 42% of healthcare physician preferred the brentuximab, while 25% ABVD or 33% is a PET directed approach. Similarly, in stage 3, stage 4, and perceived high risks of relapse in all the arms, almost more than 40% of the healthcare professional prefer brentuximab over the ABVD or PET directed approach. Similarly, in elderly, even in the younger, more fit people, there is a balance of 37 to 38%, but it's almost brentuximab has a equal or more preference in the connect study by the healthcare professionals. So in which scenarios where does this brentuximab and AVD should be preferred? At a 7-year median follow-up of high stage, advanced stage CHL, brentuximab showed a sustained PFS and OS benefit, and few lymphoma-related deaths and PFS rates suggesting the potential curability. So if you see the patients uh, with advanced stage 3 and 4 and potential with one or more nodal site involved, the brentuximab is always a winner. Similarly, with high risk IPS score that tells the higher risks of relapse, the brentuximab is preferred rather than the multi-agent chemotherapy alone. So if you see the summary of this study, OS is an important clinical benchmark, but OS advantage has seldom been demonstrated in first-line HL trials. ABVD is still widely considered a standard of care in frontline advanced Hodgkin lymphoma, but bleomycin associated with a significant toxicity and significant proportional relapse or they are refractory to the treatment. Studies over the past decade has attempted to improve the ABVD-based regimen using intensified chemotherapy regimen that can further increase the toxicity. So when we want to cure with giving the intensified chemotherapy, but the toxicities increases and that leads to the morbidity and mortality with such patients. So this study sought to improve upon the ABVD by replacing Bleo with novel agent brentuximab, and follow-up at 7 year demonstrated the significant OS advantage of brentuximab arm over the ABVD arm with 38% decrease in the risk of death and managing the safety profile. And it is a first regimen to improve upon the OS of ABVD in direct comparison head-to-head trial. And brentuximab improved OS versus ABVD despite the wide availability and use of active salvage therapies, including a substantial use of subsequent brentuximab vedotin in ABVD arm. The OS benefit was coupled with fewer secondary malignancies versus the chemotherapy. That is the very interesting part because we are aiming for cure, so we have to manage the long-term toxicity as well. So thank you everyone, especially the Takeda team and Suresh Advani sir for inviting me for such a wonderful webinar. Thank you.
Thank you, sir. I would request Dr. Suresh H. Advani to give expert comment. Over to you, sir.
Yeah. So as I could hear all the experts talking about the whole area of the Hodgkin disease, how to really modify our the so-called standard ABVD chemotherapy. I think as the more and more advances have occurred, it has become very clear that we can get a better responses with the modern drugs, particularly through advances. One is the CD30 targeted therapy with brentuximab. And I think that has played a major role in improving not only the improvement, but also it reduces the side effects completely. So any drug which we stop uh, or exclude, like we exclude the ABD, the B is excluded, bleomycin is excluded. So the side effect of bleomycin totally no more. So I think these are the main advantages of this targeted therapy. And of course, the other drug is also important, nivolumab, which also plays an important role. So I think the time has come for us, even in early cases, that we should exclude all these drugs which are much more having side effects. Similarly, the exclusion of the adriamycin with the cardiac toxicity, whatever it is, have to be ultimately thought of. And I'm sure soon newer combinations are coming up where the adriamycin is almost excluded. So I think the time has come for a radical change in our approach to the Hodgkin disease. Thank you.
Thank you, sir. I would like to welcome our next speaker, Dr. Ravi Kumar Wategaonkar, medical oncologist and hemato-oncologist, MOC, Pune. Over to you, sir.
So my slides are visible.
Yes, sir.
Okay. So good evening, everyone. At the outset, I would like to thank Takeda team for giving me this opportunity. Today, I will discuss my small experience of brentuximab in relapsed refractory Hodgkin's lymphoma. We all know for Hodgkin lymphoma, ABD is availability of newer drugs like brentuximab and immunotherapies. The standard of care still not changed. Still, our maximum patient there is ABD is the standard of care. So in future, probably with results of newer studies, the standard of care will change. So I will start with my case. My patient was 28-year-old male. Uh, he was present weight loss and palpable lymphadenopathy. Uh, we did biopsy and biopsy showed classical Hodgkin lymphoma. RS cells were seen and patient was positive for CD30, CD15. For staging, we did PET CT, and PET CT showed lymphadenopathy on both sides of the diaphragm. Then there were liver as well as bone marrow lesions. So it was stage 4 disease. So this is 28-year-old male stage 4 Hodgkin lymphoma. We started first line therapy, which was standard of care at that time, ABVD. We were given two cycles of ABD, and after two cycle PET CT was showed partial response. We continued with ABD, but unfortunately after six cycle we did PET CT and it showed persistent metabolically active disease in mediastinum as well as there were new sites of involvement. So patient has progression after 6 cycles of ABUD. So it was a primary refractory disease. So we have young male and primary refractory disease. We started him on standard second line therapy, GDP, and our plan was after 3 to 4 cycles of GDP, we want to plan autologous stem cell transplantation. So patient received 3 cycles of GDP, and after 3 cycles of GDP, patient had complete metabolic response. So after fourth cycle, he underwent autologous stem cell transplantation. So patient was kept on regular surveillance, but unfortunately, follow-up at the follow-up within 6 months, patient had a relapse. So this was a case of Hodgkin disease post-transplant, post-autologous stem cell transplant. He has early relapse within 6 months of autologous stem cell transplantation. So let us discuss SGN 35 trial, where they studied brentuximab in patients of relapsed and refractory Hodgkin disease. So in SGN 35 study, it was international single-arm multi-center phase 2 study. They were evaluated overall response rate in heavily pre-treated post-transplant patients with IRF assessed key points. So, key inclusion criteria for this study was patient with relapsed refractory Hodgkin lymphoma, and those patients after high dose therapy and autologous stem cell transplantation, age more than 12 years. Patient has FDG avid diseases by PET and with good performance status. Patient has received multiple lines of chemotherapy. Patient underwent high dose chemotherapy and autologous stem cell transplantation. Total number of patients were 102, and they were subjected to brentuximab, uh, 1.8 mg per kg every 3 weekly cycle. So total cycles were planned 16 cycles, and CT scan was done after second, fourth, seventh, 10, 13, and 16 cycle. PET CT was planned after fourth and seventh cycle. So primary endpoints were overall response rate, and key secondary endpoints were duration of response, CR rate, progression-free survival, overall survival, and safety concerns. So these are results from HN 35 trial. So you can see overall response rate in this study was 75%. So 75% patient having either complete response or partial response, and 34% patient achieved complete remission. So graph on right side showing almost all patients they have some tumor reduction, and we can see more than 50% patient they have uh, majority patient have more than 50% tumor reduction. So overall response rate was 75% and 34% having complete metabolic response with brentuximab. So median time to achieve response for overall response rate, it was 5.7 weeks. So after 2 cycles, majority of patient responded. And regarding complete remission, median time for complete remission was 12 weeks. So at the end of fourth cycle, those patients who achieved remissions. So in our patient, we are treated with ABUD, then GDP and autologous stem cell transplant. He relapsed within 6 months of autologous stem cell transplant. We subjected this patient to single agent brentuximab, and dose was 1.8 mg per kg every 3 weekly. At the end of fourth cycle, PET was showing a partial response to treatment. We continued brentuximab for another 4 cycles, and at the end of eighth cycle, patient had a complete response. As we have to stop brentuximab because of some financial constraint, so patient was kept on surveillance, and till that patient is on regular surveillance with patient has no signs of disease relapse. So this is PA patient OS data from HGN 35 study, where single agent brentuximab used in relapse refractory patients. So total number of patients were 102. Out of that, 34 total outcomes were seen in 98 patients. Out of that, 34 patients have complete response, 39 patients have partial response, and 28 patients have stable disease. So when we see PFS, median PFS, those patients who achieved complete response is not reached. Median PFS, those patients who have partial response to brentuximab, median PFS was 6.9 months, and median response for patient who achieved stable disease was 5.8 months. When we see OS curve on left side, those patients who had CR, median overall survival was not reached. Median survival 39.4 months for those who achieved partial response and 18.3 months for those who achieved stable disease. So CR is a surrogate marker for overall survival as well as progression-free survival. And a patient has achieved complete response with brentuximab had estimated higher overall survival rate was 64%, and 5-year PFS rate was 52%. Those who achieved complete response. Uh, this graph showing 5-year follow-up data for HGN35 study, and median progression-free survival was 9.3 months, and 5-year PFS was 22%. Median overall survival was 40.5 months, and 5-year overall survival was 41%. So almost 41% patient they survive post 5 year with single agent brentuximab. So regarding clinical experience, majority of patient they receive tolerate 6 to 9 cycles of brentuximab, and major toxicities are peripheral neuropathy and neutropenia. With the experience, we can manage this toxicity symptomatically. Then is another important factor. This is all about our case, but I want to discuss some data post transplant. As even after autologous stem cell transplantation, there is chances of relapse. So there was one study, Athera study, which they have tried brentuximab in consolidation therapy, and we know all know some high risk patients they have high chances of relapse, like those patients who are refractory or not responding to frontline therapies, those patients who relapse within 12 months of frontline therapies, or those patients who relapse after 12 months but they have extra nodal involvement. These are generally considered high risk groups, and these groups have very high risk of relapse. So in Athera study, which is phase 3 international multi-center double-blind placebo-controlled study, where they tried brentuximab in consolidation post autologous stem cell transplantation versus placebo. So primary endpoints were PFS as per IRF, and secondary endpoints were overall survival and safety. So majority of patient they receive frontline chemotherapy. They have relapse, and after relapse they underwent high dose chemotherapy and autologous stem cell transplantation. And after autologous stem cell transplantation, they were subject to brentuximab 1.8 mg per kg every 3 weekly, maximum 16 cycles versus placebo. So they stratified according to risk factors. Risk factors were refractory to frontline chemotherapy, or those who relapse within 12 months of frontline chemotherapy, and those who relapse after 12 months after chemotherapy, but we have extranodal involvement. So, these were PFS data from Athera trial. We can see curve started separated as early as 4 months, and they remain separated till almost 6 7 years. So at the end of 5 year, uh, brentuximab continued to provide sustained PFS benefits. Uh, PFS percentage were 59% at the end of 5 year versus 41% in control arm, which was statistically significant. And when we see PFS according to risk factors, When risk factors are increases, benefit of brentuximab more pronounced in patient with more than two risk factors. We can see that on hazard ratio, when risk factors are more than two, hazard ratio was 0.42, and when risk factors were more than three, hazard ratio of 0.39. So when risk factors are more, there is high chance that patient will get benefit from brentuximab. So median PFS for placebo group was 15.8 months, versus median PFS for brentuximab was not reached, and hazard ratio of 0.52. So in subgroup analysis, they did according to refractory, those patients who are refractory to frontline therapies, those who are relapsed within 12 months of therapy, and those who relapse after 12 months with extranodal disease. All three subgroups, they have PFS benefit, and in all three groups, these graphs you can see on left side, they separated very early, and they remain getting continued benefit till 5 years. So, brentuximab associated with consistent reduction of risk of relapse progression despite major risk factors for this progression. So, brentuximab demonstrated increased benefit in reducing risk of relapse progression among patients with two or more risk factors. Those patients who having more than one risk factor, hazard ratio is 0.57, and those who have more than three risk factor, hazard ratio is 0.43. So, when number of risk factors increase, hazard ratio decrease, means they have high chance that when risk factors are more, patient will get more benefit with brentuximab. With this, I want to conclude my talk. So there are two take-home messages. Brentuximab as a single agent, useful in relapsed and refractory patients, and those patients who undergo autologous stem cell transplantation, consultation with brentuximab as very good data, and we should consider that. Thank you.
Thank you, sir. So I would request you to give us expert comments, sir. So I would request Dr. Suresh H. Advani to give an expert comment.
Yeah, I think. Hello, hello.
Sir,
Yes,
you
sir.
are audible, sir.
Yeah, I think again this clinical study really clearly showed that how in the resistant recurrent disease of Hodgkin disease, these drugs, particularly the brentuximab and nivolumab, can play a very important role. And even replacement by one drug alone, like brentuximab, when it is included in some form with the other drugs, as compared to placebo, is a huge difference, persisting right from the 4 months onwards to the almost complete till the end of the study, that is 5 to 7 years. So I think this really indicates that this targeted therapy has become one of the important uh, treatment in the management of the Hodgkin disease. And I think in future, as the drug becomes little cheaper, we will be using more and more upfront as well. Thank you.